Thank you so much for joining us for the Caring Ambassadors Program video series, Learn from the Experts. Our main goal is to empower and educate patients and communities to be advocates for their health and to improve their lives. Today's video is dedicated to living with lung cancer, and it highlights one chapter from our book, Lung Cancer Choices. The video series is broken down into short segments, so it's easy to watch and navigate. You can watch the videos in any order, so feel free to choose what interests you the most. I'm Lauren Sant, the Executive Director of the Caring Ambassadors Program, and I'm excited today to be joined by Elizabeth Krueger. Liz will be discussing the chapter Comprehensive Biomarker Testing, written by her colleague, Kelly Goodwin. Liz Krueger is a family nurse practitioner who specializes in the care of thoracic oncology patients at Massachusetts General Hospital. She completed her Bachelor of Science degree in Healthcare Policy and Management at Providence College, and then went on to receive a Bachelor of Science in Nursing and a Master of Science in Nursing from Regis College. More than a dozen new drugs for treatment of small cell lung cancer have been approved since 2013, making an exciting and hopeful time in lung cancer research and care. With improved biomarker testing techniques, an expanding list of molecular targets, and more approved emerging therapies, comprehensive biomarker testing is an essential part of the evaluation and management of all patients diagnosed with non-small cell lung cancer. In this video, Liz will be discussing frequently asked questions from her patients at Massachusetts General Hospital. We hope that this video will provide helpful insights and information for patients and caregivers dealing with lung cancer. If you're interested in learning more about the Caring Ambassadors Program and our mission to help lung cancer patients, please watch the video series and share this information with anyone who might find it useful. Together, we can make a difference in those lives affected by lung cancer. Thank you. Welcome, Liz.
Question number 1, how does gene testing impact my kids and family, and do they need to be tested? As we discussed, most genetic alterations found from tumor testing and in ctDNA or circulating tumor DNA are somatic or only within the tumor material, so are not inheritable. This can be a really big piece of relief when a person's been newly diagnosed and we start talking about gene changes, to really emphasize that it can be a big relief to find out that these gene changes are not inheritable and are only gene changes found within the tumor. Occasionally, we pick up germline or inheritable mutations on tissue or plasma testing. And if these are found, the patient is typically referred to a genetic counselor to explore this change and its implications for children and other family members. The next question is, will this testing be covered by my insurance? The short answer is it should be. Reimbursement is variable, but many oncologists, pathology departments, and commercial labs have processes to advocate for reduced out-of-pocket costs for the patient. When working with insurance companies, we often cite the NCCN guidelines that recommends broad-based NGS testing for individuals. The Medicare and Medicaid Coverage Determination Act of 2018 also supports diagnostic NGS testing for patients with lung cancer. Another question is, why would I need a tissue biopsy if I can have a blood draw to look for cancer cells? It's a really good question. So blood-based samples can identify gene changes in the tumor, but it cannot give you a histologic diagnosis. We could find out that you had an EGFR mutation, but we wouldn't be able to confirm that this was a non-small cell lung cancer of adenocarcinoma subtype. And that's a really important piece of the puzzle when determining next steps in your treatment. Additionally, PD-L1 testing can't be performed on peripheral blood. PD-L1 testing needs to be done on tumor material with an immunohistochemistry test. And although it can be nerve-wracking to wait and go through a biopsy, there are risks of false negatives when it comes to ctDNA. If there aren't circulating tumor cells, or if the tumor is not close to a blood supply, that result may come back negative, but on closer examination of the tissue itself, you may find a gene change. The next question is, what happens when there is disease progression on a tyrosine kinase inhibitor, or TKI? We often think about repeating biopsies when possible at the time of progression, whether it be blood-based or tissue-based testing. to look for resistance mutations. I touched on that briefly, but sometimes we see MET amplification develop in the setting of exposure to tyrosine kinase inhibitors or targeted therapy. And with this specific mutation, we can add another targeted therapy or a MET-directed therapy to your regimen. So that's always something in the back of our minds. At the time of progression, we want to know, have there been gene changes in the tumor? And are these gene changes something that we can target with another approved drug? Also, there are many clinical trials going on looking at some of these resistance mechanisms. So with the more information that we get about tumors and their resistance, there are many clinical trials going on that individuals may be able to enroll in with that new information. Other times when there's progression on a tyrosine kinase inhibitor, we add chemotherapy to the pill form of medication. We never add immunotherapy, though, to tyrosine kinase inhibitors in lung cancer because of the increased risk of toxicity, particularly pneumonitis or inflammation of the lung is one, and then other types of inflammation in the body. The last question is, should I go on treatment before my biomarker testing comes back? So it can be difficult to wait. Next generation sequencing testing can sometimes take 2 to 3 weeks. So that's a long time when you've learned that you have cancer and that you're waiting your treatment plan. And this is often decided on a case-by-case basis. It depends on symptoms. It depends on the disease burden and associated symptoms, and the investigator or doctor's suspicion that you may or may not have a mutation, whether it be based on smoking history or other risk factors. Occasionally, we start chemotherapy while we wait for next generation sequencing to come back, but we don't add immunotherapy for the reasons I listed above, because we wouldn't want to give immunotherapy and find that you've had a mutation that we could target with a pill. Thank you very much for your time today, and I look forward to our upcoming patient panel to answer some more questions.